Sorry. Don't be sorry. Not at all, sir. You all right? Okay. All the jurors are present. Juror number 9 had excused himself for a few moments, and we're going to resume. Thank you.
Thank you, Honor. So let's start off, Dr. Shafer. So this scenario simulation assumes a 100 milliliter infusion.
That is correct.
Okay, and that would be, this is, People's 30 is a 100 milliliter vial of propofol?
Correct.
And can you please then just orient us to this slide and your findings?
Yes. So, as in the other simulations, this is the hours past midnight. And this would be midnight here, 2 a.m., 4 a.m., 6, 8. So I'm postulating here that at 9 a.m. an infusion was started. Just for simplicity, I have not shown a bolus injection, although one was done. If I was to add that, there would be a blip right here that would just go straight up and down almost. I'm not including that. I'm just saying, for simplicity, we'll say that a infusion starts here at 9 o'clock. And the infusion runs until 12 o'clock, at which point all 100 mils have been infused into Michael Jackson, 1,000 milligrams.
And let me go back up just a little bit. If a 25 milligram bolus was done first, followed by this 100 milliliter infusion, I mean, would that be a small enough amount that it wouldn't?
Yeah. It's a little blip right here.
Right where? Right.
I'm sorry, here.
Right at the time.
At 9 o'clock, it would have gone up to a level here of 1.5 and come back rather quickly. It would be almost invisible on this because of the difference in doses, 1,000 milligrams versus 25.
Okay, and can you take us through then the concentrations of propofol, both in the blood and the brain, under this scenario?
Right. When you give an injection of drug, just it all goes in at once. As you saw earlier, the blood concentration starts quite high, the brain concentration starts quite low. The blood concentration comes down, the brain concentration goes up. When you're giving the drug slowly with a drip, there's not much difference between the blood and the brain. And so both are shown here. We actually have the dotted line, which is the blood, and the solid line, which is the brain. But they're pretty much on top of each other. There's not much difference here between the blood concentration and the brain concentration. So both are shown here, but you can really only see the difference right here a little bit after 9 o'clock. But what happens, this shows the accumulation of propofol during a continuous drip. Initially, the levels rise quite quickly until you get to a concentration that is high enough that the amount of drug that the liver metabolizes is about the same as the amount of drug that's running into the patient. And so after about an hour, you can see here where things start to look pretty steady. It would appear to an observer who didn't understand propofol kinetics that maybe everything was stable. But everything is not stable. The reason everything is not stable is if you look at this, the levels are continuing to rise. The reason they're rising is that the amount of propofol in the fat of the body and in the muscles, the amount of propofol in these organs is rising up, and it's filling up those tanks. It's filling up those compartments in the body. And because it's filling up those compartments in the body, the levels continue to rise during this time period. So here you're at the apneic threshold. But as I mentioned, that's just where 50% of patients would not be breathing. When you approach this apneic threshold slowly, when you approach it slowly, what happens is that your rate of breathing slows down. It's a little bit complicated, but the rate of breathing slows down.
We're embarking on a narrative.
You can stop it here. The objection is sustained, and Mr. Wogan, you can follow up. Thank you.
Between 9 and 10 a.m., his breathing would have changed.
Correct.
Okay. And his breathing would have slowed down?
Correct.
With his breathing slowing down, and that would be at a relatively slow pace,
Correct.
his carbon dioxide in his blood would be going up?
That is correct.
Can you explain that, please?
The amount of carbon dioxide in your blood is controlled by how fast you're breathing. If you breathe very quickly, you lower your carbon dioxide. If you hold your breath, your carbon dioxide rises. If there had been capnometry, you would have seen the increased carbon dioxide. Capnometry is measuring carbon dioxide. You would have seen, during this period in time, the rise in carbon dioxide.
Which would stimulate continued breathing to some extent.
Correct. It's protective. As your carbon dioxide goes up, it makes you want to breathe more. It's actually your carbon dioxide that keeps you from holding your breath until you die, because your carbon dioxide is a very powerful stimulant of breathing. So his carbon dioxide would have been rising, and it would have kept him breathing. The rise in carbon dioxide would have kept him breathing initially through the apneic threshold.
And this specific...
Is this a hypothetical?
I believe it all
Yes, yes.
assumes.
Is that an objection?
Well, it is an objection because it's stating a fact as opposed to in this hypothetical.
Right, the objection is overruled. You can ask your next question. Thank you.
This specific issue that you just touched on regarding propofol concentration, carbon dioxide, and breathing, you've actually studied this yourself, correct?
Correct.
And can you describe that, please?
Yes. Thomas Bouillon was a fellow of mine at Stanford and put together a specific pharmacokinetic dynamic model, the kind of mathematical models, that looked at the rate of breathing, propofol concentrations, and carbon dioxide, and modeled exactly how carbon dioxide and propofol affect breathing. Propofol decreasing your desire to breathe, carbon dioxide increasing your desire to breathe, and how they balance each other out. So, yes, we've published on that.
And that was published in the journal Anesthesiology
That is correct.
in 2004?
I think so, yeah.
So with this explanation of, based on your expertise, what would be happening, what's going on at 10 a.m. then?
At 10 a.m., his carbon dioxide levels are higher. With his higher levels of carbon dioxide, he is continuing to breathe here. And because there are no other vital signs, and he's on supplemental oxygen, even the pulse oximetry reading is probably just fine. And so a examination that did not include careful analysis of breathing and end-tidal carbon dioxide monitoring would suggest that maybe he was now comfortably asleep.
Now, at some point, is the extra stimulation created by the carbon dioxide, at some point, is that no longer able to keep the breathing going?
Correct. Because the propofol levels are still going up. The propofol levels are continuing to rise, and he is getting further and further into the danger zone. And the carbon dioxide can only compensate so far. And as he reaches near noon, the carbon dioxide is no longer able to drive his ventilation and compensate for the propofol that is accumulating in his blood. And with that, he starts to slow down his breathing to the point of apnea.
Could this slowed breathing at that point in time have been detected?
Absolutely.
How?
It would have been detected initially with measuring the carbon dioxide, what's called capnometry. And as the breathing got so slow that he was not bringing enough oxygen in, it would also be picked up with pulse oximetry.
And what if Conrad Murray had been at the bedside making physical observations?
Making physical observations, you would have seen the breathing slow down. You might have also seen, perhaps, that the airway was compromised by the tongue falling into the back of the airway, which would just instantly stop the breathing. So had Conrad Murray been at the head of the bed, no, the head of the bed is irrelevant, if he had been with the patient, if he had been with Michael Jackson during this period of time, he would have seen the slowed breathing and the compromise in the flow of air into Michael Jackson's lungs. And he could easily have just turned off the propofol infusion, done some chin lift, maybe put it in an oral airway, in worst case, bag, mask, ventilation. He could have easily done these things, and there would have been no injury to Michael Jackson.
Going to the scenario then at about 11 o'clock, let's say from 11 to around 11:45, what's taking place?
From 11 to 11:45, Michael Jackson's breathing is getting slower and slower, and he may actually start to have some interruption in the breathing, sort of as the tongue goes into the back of the throat.
And that would have been actual audible sound as you've made?
It was audible because I made it audible. Perhaps, perhaps not.
Okay.
The key is that when you're there, you see it, you know it.
And at about noon, then, what is taking place?
And about noon, the flow of oxygen into Michael Jackson's lungs stops. Sometime in here, actually before noon, I'm going to say perhaps at 10:45, pardon me, around 11:30, 11:45, the flow of oxygen into Michael Jackson's lungs stops. And with the lack of oxygen going into his lungs, in 10, 15, 20 minutes, the lungs no longer have enough oxygen for the heart, and the heart stops. And with the ending of circulation, Michael Jackson has died, but he's died with the infusion running. And that's why the levels are high. He has died with the infusion still going. So there's no opportunity for this rapid metabolism of propofol to occur. That's why the concentration in the femoral vein, not only is it identified here, but you'll notice it's right near the apneic threshold. It's right near the apneic threshold. And that's completely consistent with Michael Jackson dying on an infusion, a drip of propofol.
And in this scenario, it's consistent then with the femoral vein found as a result of the toxicology testing?
That is correct.
Okay. And the levels of propofol in the femoral vein?
It's consistent with the levels of propofol, and this is the only scenario that produces the levels of propofol in the it's the only scenario I could generate. In looking at scenarios, this was the only scenario that I could generate that produced the femoral vein concentration in a way that was consistent with how Conrad Murray described his usual practice of administering propofol to Michael Jackson by drip.
And is this also consistent with your consideration of the 130 100 milliliter vials that Conrad Murray had ordered and had shipped?
Correct. He ordered enough vials so that every night he could use a 100 milliliter vial on Michael Jackson. He ordered 130 of these vials, and he was only using them for a period of 80 days. So that suggests one vial per night, with more ordered for the future there.
And is this consistent with Conrad Murray's statement that at some point he left Michael Jackson alone in the room?
Yes, because at this point in time, not knowing that the breathing had slowed down, not knowing that the carbon dioxide was elevated, and having observed for a period of perhaps an hour or so that everything looked okay, he might have thought everything was okay and walked out of the room while the